Yeah, before. Let's humble ourselves for a word of prayer. Heavenly Father, we want to thank you for a new day. We thank you for the gift of life. We thank you for the organizers and for the good weather. We pray that today, as we gather together, give us good health once again. Lead us through the discussions that we're going to have here. Refresh our minds, and whatever that we shall discuss here, that will be for the good of our country and for of our communities. We thank you for all the partners that are here, and we thank you for everyone. In Christ Jesus we pray.
Thank you very much for that wonderful prayer. This is the third annual Community Health All Partners Retreat. It is intersectoral. We have Ministry of Local Government. We have Office of the Prime Minister. We have regional referral hospitals. And in them we have embedded community health departments within them in order to deliver services to the community. We discussed a lot yesterday. We ended very late. And therefore we have a rapporteur team. The rapporteur is going to give us a recap of yesterday, but it has to be very, very brief. So I call upon the team. I hope you are organized. I request one of you to come up and take us through a recap. As they are preparing to come, I would like to recognize the presence of Commissioner Dr. Salami Achika. Stand up for recognition so that people may see you and you are in attendance. That's very good. And I also welcome one of the civil society representatives. Please stand up for recognition. That's very good. So, rapporteur team, whoever is near the rapporteur, please inform in that you're starting. So, Chairman, come and give us a recap, a brief recap. Work with all your heart. Whatever you do, do it effectively. So, the rapporteur, so those people who are outside, come and occupy the spaces inside. Okay, so we skip the recap if you are not ready. As they are rolling, you sit. Have a seat. So, like I said, we have so many agencies represented, including partners, implementing partners. And this is an announcement. If you are an implementing partner and you have not come with your banner, you are not present. And the banners, we have made an arrangement that they are supposed to be put alongside as you are sloping down from the gate. IT team, can you please load? Okay, so the floor is yours.
Good morning to all of us. All protocol observed. I'd like to just take you through, give you a brief of what we went through yesterday. And I think starting with our key objectives, of which I'll just try to re-echo. Reviewing, we're here to review the community health program performance of partners and stakeholders against the community health indicators. So we're going to be able to look at that throughout our retreat. to be able to assess alignment with Ministry of Health strategic directions and community health priorities. That is our second objective, the reason as to why we are here. Then our third is to be able to build consensus on integration of community health programs and dissemination of integrated essential community health service package that is in our new guidelines that is going to be launched in this retreat. Yesterday we were able to look at the concept of integration and how we're going to go about it in the community health space. And then we have profiling and zoning community health partners for improved coordination and to ensure equitable community health service delivery. So those are the key objectives that are gathering us here, and it will enable us to ensure we put a way to healthy populations. So the key focus areas that we went through yesterday was performance evaluation, which spoke to assessment of the community health program performance against the established indicators. And then we looked at overview of the strength and the areas of improvement. Then we looked at strategic alignment. That is alignment to MOH strategic direction. That's what we looked at. Then we looked at program integration, which was a very key component of discussion, which we looked at building consensus of the integrated community health programs, and then dissemination of integrated essential community health service package, which we already have, and we're going to look at in the following sessions. And then we have partner profiling and coordination, looking at profiling all the partners in the community health space and zoning partners for improved coordination as stated before. Then we look at the recommendations. So what are the things that key points that really came up during our discussions is to implement a robust monitoring system to be able to track community health programs. And then the other one is to be able to conduct regular assessments to ensure alignment to MOH strategic directions. And then we have comprehensive integration plan. If we're speaking of the concept of integration, we should have to forge a way of understanding how we are going to integrate the community health, the intervention within the community health space. And then establishing clear communication channels for partner profiling and zoning. Then to be able to create a framework for equitable community health service delivery across the zone. So that was just the highlight. And then there we have a complete session that I am not going to read through. And we look at the challenges and integration in the primary health care, where it's highlighted the importance of primary and work effectively with the different partners in the community health space. And the challenges and opportunities that we're able to look at is shrinking the shrinking financing for health programs, then restriction on the civic space, then need to identify and address the gaps in the community, in community health services. Then we're able to look at community engagement and supports. How can we be able to involve communities to be able to own their own health and take up these preventive measures to prevent diseases? And then we looked at capacity building and government support. That capacity building is still comes to empowering the communities. And then we look at the perspective
Not far from having an essential health care package. What is this essential health care package for Uganda? It's not so sensitive. As far as that topic is concerned, we started with the Uganda National Minimum Health Care Package. And I'm sure every health worker or health manager sings about or talks about the Uganda National Minimum Health Care Package. But this started way back in the year 2000 when we developed our first national health policy, and it had 12 components. All these 12 components, as you can see them, were derived from the programs that were being implemented then. You remember that is the time when most of our services were externally funded. We had lots of funding from different partners, and with that we had programs. And those programs were actually used to define the essential health care package then. In the year 2010, we revised that essential health care package as we were developing our second health policy. The 12 components were collapsed into 4 clusters. That's what we have now been looking at. What are the 4 clusters of the Uganda in the year 2010 essential health care package? And as you can see, they had health promotion, disease prevention, community health initiatives, maternal child health, communicable disease control, and NCD control. And that's what we have been moving. We revise and most of the programs fitting within that. That is during the period of the second national health policy. So when you refer back to my earlier slide, we say in the UHC roadmap, we need to revise or review or develop an essential health care package. So what did we do? We evaluated our national minimum health care package 2010 in the backdrop of a UHC vision, ensuring that all people have access to health with a full range of quality health services they need, when, where, and they need them without financial hardship. And we use the guiding framework that is developed by WHO to see that we meet the needs of all the population segments. So our key areas of focus were inclusion of a multi-sectoral perspective reflecting universal health care and the SDG agenda, not looking at the health sector alone, but also the non-health sectors. What do they have to contribute to health? So the package the package articulates that. We also ensured that we have a holistic package looking at promotive, preventive, palliative, curative, and rehabilitative services. More important, we ensured that we address the life course approach. And in the definition of the services, we had to align to the ICD or International Classification of Diseases so that we can be able to standardize our reporting with other globally and also regionally. And also ensure that we maintain the primary health care approach, because as a country, the PHC approach has contributed a lot to improving our health indices. Also, we ensured that the public and private mix is maintained, aligned to the financial trends and available resources. We don't need an ambitious package. We needed a package or interventions that fall within the resource envelope. And also, it is to be implemented in a phased manner. It doesn't mean that each and every service defined should be implemented as of today, but this should be looked at as a package that will be implemented in a phased approach. So what is the Uganda National Essential Healthcare Package? It is a package of essential, cost-effective, affordable, preventive, promotive, curative, rehabilitative, and palliative care services provided universally to the population in Uganda relative to need through a multi-sectoral and collaborative approach. Our goal is to increase universal health care coverage index, service coverage index in Uganda from 49% by 2021 to 85% by 2030 through delivery of an affordable and responsive health benefits package. This goal is ambitious, but you all know when you are setting goals, you need to set a goal that is high enough to catalyze everybody, to wake up everybody to contribute to that achievement. The other thing I would like to note is that the 49% UHC coverage does not take into consideration our current achievements as far as life expectancy is concerned, as far as reduction in maternal, neonatal, child mortality, and other indicators that have recently been published. So when you factor those in, probably we are in the 50s, somewhere in the 50s now, when you factor in the UDHS, census, and other survey findings as of now. So, what are our specific objectives of this package, of the essential healthcare package? One was to define the package of health and non-health services to be provided, to ensure equitable access to quality services right from primary, secondary, tertiary, and now quaternary healthcare services. Many of us have been knowing that our service delivery structure stops at tertiary level. That is the national referral. But we have graduated to that, from that, to include, to show that we are also looking at super specialized services. Those are what we call the quaternary care services. So please remember now, we don't only have 3 levels, but we have up to the quaternary level. And this is to ensure that we have services across the entire life course. Quaternary care takes care of many of the services that we are now bringing in, looking at the elderly, now that life expectancy is going on and quality of life is improving. The other objective is to guide resource investments in the health sector, knowing that the package has defined high impact interventions. There are many interventions, so if you don't see some of them, don't say, oh, what about this? But we tried to pick out at least some of the key interventions or high impact interventions. And lastly, to enable equitable, efficient, and sustainable resource mobilization and utilization. When we talk about the life course approach, what do we mean? In this package, we have ensured that we have taken care of everyone, right from pregnancy level or the unborn child to the newborns, the young children, older children, the youth, adults, and as well as the elderly. That's what the life course approach. The package should be able to show that certain services are targeted to to certain populations as the need arises. So what is key, or what are the major changes or highlights in this essential health care package? We have maintained clusters 1, 2, and 3. That is health promotion, disease prevention, community health initiatives, management and control of communicable diseases and non-communicable diseases. Cluster 4 of maternal and child health, we have clearly also brought out the focus on reproductive, newborn, and adolescent health. The last 3 clusters, surgical and anesthesia care, emergency high dependence and critical care, and geriatric care, were not previously of focus in the previous, in the minimum health care package. And if you all recall, many times when you interact with the secondary level and tertiary level or care service providers, they would say, but that package does not care for us. That is the referral hospitals. They saw that it was a primary health care package. But now, with bringing in these other more or less clinical-based services, I think now everyone should feel part of this package and ensure that they contribute to its implementation. So, I mentioned you'll have, if you don't have access, you'll have access later on to the detailed package. But for purposes of this conference, I felt that I needed to dwell more on cluster 1, and we all understand the intervention. So I'm more or less doing dissemination of cluster 1 of the Uganda National Essential Health Care Package. So it has 9 key interventions, and I should say that almost all of you who are in the community health field, you can see where you belong or you contribute as far as service delivery is concerned. And I'm going to go through the services that we have spelled out in the package that are to be provided under each of these interventions and the level of provision. So under health promotion and education, there are a number of interventions that are to be provided. Actually, they are about services that are to be provided. But we need to emphasize that when we are in the health promotion and education arena, you should be able to provide health education and prevention for early detection of communicable diseases, including NCDs, mental health, injuries, and all the others not mentioned. But when we talk about health education, it should cover across all the program areas. And this starts from individual level, because we know people can read, can teach themselves. So it should start from household, individual, community, schools, health facilities. And the word community here, I would ask my commissioner, Dr. Pencil, when we say community, what do we mean? Definition of community. Dr. Pencil, because we need to understand when I say community, for example, in this context, what do we mean? You'll go through that in your presentation. So Dr. Pencil has packed that. He'll highlight what we mean by community. We are not talking only of community, I'll go to the village and talk. We have many communities. Okay? So that's one, when I say community, don't just think yourself in restricted to the village somewhere. Okay? So that should be given to everybody. We have education on health, well-being, environmental health, sanitation, pollution, and climate change. So the people in environmental health, you see where you start. Health education on feeding and nutrition. The nutritionists, you see, the package is there. Age-appropriate information on sexual, reproductive health and behavior change communication. This is provided, but it is across the scope, right from national, district health facility up to community level. And we have SBCC for health and well-being across the life course. So when we talk about health education and promotion, those who are developing the health education and promotion interventions, this is actually the starting point. This is where we are, all of us. Next is sanitation and hygiene. What do we expect under the community health initiatives or at that platform? Home visiting and promoting improved sanitation, personal hygiene, sanitation in social institutions, safe water provision at households and public institutions, disposal of waste and environmental sanitation in urban areas, as well as food inspection and certification. And you know, when we are sending this primary health care grant to local governments and telling them that money is for health, education, promotion, disease prevention, they are getting lost. They don't know what services. They think it's just for going to radio, going to an outreach. So we are unpacking what are those services. We need to see the health assistants planning for this. Health educators with clear activities, going out, not just sitting there and saying, but what is this? They are totally lost. That is what the 30% PHC grant is supposed to do. So the money is there, at least government contribution towards this. The issue is everyone to know what they are supposed to do. What interventions are we talking about? There is emerging environmental health problems, pollution, climate change. We should be looking at promoting safe housing conditions, safe use and disposal of reusable plastics, tree and forest planting, promoting the use of clean fuel and domestic use. So this, as we said, there are other sectors that come in. It may not be only health, but are you working with the environmental health officers, the CDOs, and other people to be able to deliver these services in the community? Another initiative of disease prevention is immunization. Many times we are taking immunization as a curative service. It is a preventive service. And people say, oh, health prevention is not well funded. We have a very strong program, the immunization program, which is on prevention, disease prevention. And we are doing very well as far as reduction of child mortality because of this program of immunization, which is disease prevention. So yes, the district's facilities have been doing well because most of their outreach money is on EPI. But you can see it's beyond what? EPI, routine immunization. I don't have to talk much about that. But we start from community in terms of outreaches, although it is largely facility driven, but we use the community platform to reach those people that have not been able to access services. Under vaccination, we have the routine but also emergency vaccination, as you have seen from these outbreaks, and it's also conducted. And most of these actually emergency vaccinations are largely delivered through community level platforms. Next is prevention of communicable diseases. We have not listed all the communicable diseases, but picked out the key priority diseases: HIV, TB, and malaria, STIs. So here, what do we see in terms of prevention? HIV testing and counseling, STI testing and treatment, self-male circumcision, and ART for EMTCT. No, ART for EMTCT is a prevention service, but it is only provided in accredited facilities. So that one is not really for community level, though it is for prevention and HIV prevention intervention. And as you can see, under targets, we have the key targets or the beneficiaries of these services. Next is TB prevention, which starts also at community level through active search for TB, screening, and that's where the CAST program has been anchored. CAST, I think this you see is CAST. And people are saying, how do we use CAST to implement others and all those discussions? But you can see the TB initiative is just one of the programs, but it is actually down on the ground. And if you are asking yourselves what other packages can be added on, there are very, very many. And if you overload it, it might fail. So sometimes you need to focus. If everyone says, I'm going to go through CAST, then you might lose focus. But you can, we promote integration, we promote, but let us do it in a way that we don't lose the intention of that program. Prevention of malaria, we have interventions at community level, which in fact start with the use of the LLIMs. Our demographic health survey showed that during the last campaign, the household ownership of nets was up to 99%, but utilization is only 68% of the nets. People have them, but they don't use them, which means that these interventions may not have the impact or result you expect because of non-use. So the issue of prevention, even at individual level, like use of nets, is really important, and all those other aspects of malaria control, which have to be undertaken. And you cannot succeed without having the community embracing them and participating. I have a colleague who says they are working on a malaria eradication plan. So in the eradication plan, the community has to own, they have to embrace these interventions if we are to succeed, and therefore need to be aware and educated. Vector control is another area. Not all well, we have vector control, which starts also at household level. I see my colleague there. They are not left out. The vector control officers, they have a lot to play. Many of them are redundant in our facilities, health center force, district. We still have district vector control officers in the structure. You have a role to play in community health, and also see how we can address these rodents in institutions, households, schools, workplaces, even in our offices. You walk in an office and it's full of cobwebs, it's full of cockroaches, even bats and rats, but you have a vector control office. Even in his own office. We have the NTDs. NTDs, we also have a key role to play in community health, prevention, mass drug administration, and vector management using traps as well as larviciding. This is an area, although because of its nature, it is largely, it's implemented at community level, but we also need a lot of support in terms of resources from the center to be able to achieve this mass drug administration. Prevention of worm infestation, deworming, right from household to facilities, and we have target populations. So when we are talking about prevention, many people, some of these services are facility-based, but they can also be delivered by individuals, by institutions, and also health facilities. Then we go to the next is MCDs. MCDs. Here we are looking at interventions for reduction of risk factors for NCDs, which are many, but at community, we are looking at aspects of enforcement of our laws, like substance abuse, tobacco control laws, enforcement of age restrictions of alcohol consumption. I know the law has stalled, the bill has stalled because of many factors. It's an economic, it has alcohol industry generates revenue for government. So when saying we impose restrictions on alcohol production and all, so somehow, but what we need now to emphasize is at least age restriction of alcohol consumption, and as well as key is individual and group physical exercising, healthy eating. NCDs know their package. We need really to promote it. Many times when people say, oh, they are going for school health outreach, they even ask, what do we do? Apart from maybe giving HPV, TT vaccination, general talk about HIV, you don't hear about substance abuse, alcohol abuse, how to prevent. You don't hear about healthy eating. So there is a lot. Health educators and whoever, as you go to these schools, there is a lot that you need to develop your schedules or your packages so that we address all these aspects in the package. Then institutions